Hello, it's Dmitry again. Today we'll be going back to the Mehlman Medical PDF for internal medicine, this time on ophthalmology. So basically I have a handful of chapters left. I have ophthalmology, and I believe I have, what is it again? Biochemistry. And there's like some mixed bullet points at the end that I plan to probably not do. So this will probably be one of my last videos for Mehlman Medical PDF for internal medicine at least. So let's get into it. So internal medicine ophthalmology. We start off with a little diagram right here that has showing sort of this circuitry for the eyes. Left eye, right eye, retina, optic nerve CN2, optic chiasm, optic tract, left geniculate nucleus, optic radiations, calcarine fissure, upper bank, calcarine fissure, lower bank. It says H, K if PCA is occluded. These other things here. So A is the central scotoma right there. B is going to be here's an important. These are the pathologies. So A would be a central scotoma, okay, and it creates that presentation in the eyes when you're looking around. There's a spot in the middle. You can read if you want to. B would be a monocular vision loss in the one right eye. Makes sense. D would be, I believe, what is it going to say? Okay, it's for, well, let's do C first. So C going right down the optic chiasm would be the bitemporal hemianopsia. So this is like tunnel vision, I guess. That's the way I would phrase it, but I don't know if this is technically the correct way to phrase it. Nevertheless, you can see in front of you with difficulty having vision to the left or right. What about D? D or G. Yeah, so D or G or H all are going to have basically very similar presentations, which is going to be contralateral homonymous hemianopsia. So basically, if you knock out that stuff on the right side, you will have a left-sided homonymous hemianopsia, where you can't see on the left side in both eyes, which is very, very interesting finding. If you have a lesion at E, or a lesion at J, trying to find where J is located. So J is right there. J is in the calcarine fissure of the lower bank. E is in these the circuitry for that leads to that calcarine fissure lower bank. If you have lesions there, well, you're going to have this thing called contralateral superior quadranopsia, which is pie in the sky, temporal lobe issue. What if you have F lesion or I lesion? Those are messing with the upper bank of the calcarine fissure. Well, in that case, you have pie on the floor, parietal lobe. So you have pie in the sky, temporal lobe, pie on the floor, parietal lobe. Contralateral homonymous hemianopsia with macular sparing. That would be caused by K if PCA is occluded. K if PCA is occluded. And K would be, we're talking about H before contralateral hemianopsia. Okay, because it could be happening there too at the calcarine fissure if you just knock out both banks. But K could be happening if the PCA is occluded. But you have macular sparing for that. Okay. So extraocular nerve palsies. You have A, B, C. So A, let's say you knock out cranial nerve 3. This is kind of goofy. But if you knock out cranial nerve 3, you have an ipsilateral down and out presentation. It presents with a down and out eye. Yeah. That's oculomotor nerve. Let's say you knock out cranial nerve 4, which is trochlear nerve. What happens in that case? Well, then you have an eye that is going to be presented as an upward gaze, plus the patient will tilt their head toward the unaffected eye. I always hate when they say toward the unaffected eye, as in what on earth do you mean? Because when you look at a picture, they're not going to tell you which eye is toward the affected eye. They're going to show you a person with their head tilted. I believe it's the eye that is tilted that is the eye you choose, I think. If memory serves me correctly, which it may or may not. But I believe it's the eye that is higher up is the eye of the side of the lesion. So let's say if you have a left eye that's higher than the right eye, then the left eye, which is higher, would be the side of the lesion. If you have one of these guys with a trochlear nerve problem. So let me go figure that out. right now. Okay. Trochlear nerve palsy picture. So let's find trochlear nerve palsy. I'm just looking at pictures right now. I hate when they don't specify which one it is when they have doing this head tilt thing. I think it's the eye that's higher is the one that's the side you choose, I think. If I were you, I would just look into it. So, but let me go back to it. I might not be able to find something in a reasonable amount of time. I'll look at that. If you want to look into it, you can. Cranial nerve 6 palsy, abducens nerve lesion, medially directed eye. Yeah, so if you have an abducens nerve issue, that means you cannot abduct the eye on that one side, right? Abducens, abduct. You cannot bring the eye laterally on that one side. It's stuck medially, or at least towards near the center. It can't really go to the lateral portion. And so let's say, for example, you need both of your eyes to turn to the right. Well, your left eye can do that because it can go medially. And your right eye, let's say if your right eye has a lesion, well, then it can't go medial. It cannot go laterally. It has a lesion in that eye. If you have a situation where it's the opposite, where it can't go medially, but it can go laterally, but has a medial issue, in that case, it's going to be an LGN issue, a lateral geniculate nucleus issue. So if it can't go medially, it's LGN issue. If it can't go laterally, that's a cranial nerve 6 abducens issue on that side. What about glaucoma? We have two different kinds of glaucoma, typically, is what we think about. We think about open angle and closed angle. So open angle glaucoma, chronic eye condition characterized by increased intraocular pressure due to the impaired drainage of aqueous humor. Unlike acute angle closed angle glaucoma, the drainage angle canal of Schlemm between the cornea and the iris remains open. Progresses slowly and is usually painless. As it advances, causes peripheral vision loss, tunnel vision, and results in optic nerve damage characterized by cupping of the optic disc, that is to say, an increased cup-to-disc ratio. The USMLE wants tonometry as the first step in management, measures the intraocular pressure. Treatment for an open-angle glaucoma for USMLE is not going to be a trivia game of which drug first. They just want you to know the topical prostaglandins such as latanoprost can increase outflow of the aqueous humor, thereby reducing the intraocular pressure. Now, the topical beta blockers such as timolol decrease production of aqueous humor. Carbonic anhydrase inhibitors such as dorzolamide decrease production of aqueous humor. Pilocarpine is a muscarinic receptor agonist that constricts the pupil and increases outflow of aqueous humor. What about closed angle? Presents on USMLE as a very buzzy red, teary, fixed mid-dilated pupil. Due to the closure of the drainage angle canal of Schlemm between the cornea and the iris, leading to a rapid increase in and intraocular pressure, can lead to compression of the optic nerve and blood vessels, causing severe symptoms such as intense eye pain, headache, nausea, vomiting, blurred vision, and seeing colored rings or halos. Similar to open-angle glaucoma, the USMLE wants tonometry as the first step to confirm increased intraocular pressure. Treatment is IV mannitol, helps draw excess aqueous humor out of the eye. Timolol, pilocarpine, muscarinic receptor agonist, or alpha-2 agonists such as bromonidine. Macular degeneration. USMLE wants you to know that wavy lines on a straight line Amsler test equals macular degeneration. It is characterized by a loss of central vision. Fundoscopy shows drusen, which are yellow lipoproteinaceous deposits. There are dry, atrophic, and wet neovascular types of macular degeneration. Most commonly occurs idiopathically due to the age, that is to say, age-related macular degeneration. Dry is treated supportively, wet is treated with anti-VEGF agents and sometimes laser therapy. What about retinitis pigmentosa? Presents on USMLE as a combination of nyctalopia, loss of night vision, and a loss of peripheral vision. There will be a family history, oftentimes. Fundoscopy shows a characteristic pigmentation. What about retinal detachment? Occurs classically in those with sudden trauma to the eye or severe myopia. The fundoscopy is high yield and important for USMLE, especially 2CK. Treatment is surgical and includes pneumatic retinoplexy, that is to say, gas bubble is injected into the eye to push the retina back into place. Scleral buckling, piece of silicone is attached to the sclera to exert posteriorly directed pressure so the retina reattaches. Oh, interesting. In vitrectomy, vitreous humor is removed and replaced with gas or silicone oil to flatten the retina. Vitreous hemorrhage. USMLE wants you to know that the biggest risk factors for bleeding into the vitreous are diabetes and hypertension. Vitreous hemorrhage will usually be a distractor. Well, they'll tell you a young boxer was hit in the eye, but the answer is retinal detachment, not vitreous hemorrhage. Retinal detachment. Central retinal artery occlusion. Presents a sudden painless vision loss in patient where a current comes down due to a carotid atheroma in the setting of hypertension or a left atrial mural thrombus in the setting of AFib that's launched off the retinal vessels. A pale retina will be seen on fundoscopy with a cherry red spot due to the maintenance of perfusion from choroidal artery. Okay, ocular massage can be attempted as treatment where the embolus may be dislodged, restoring perfusion. Well, how about that? USMLE is this just the continuation of this? Yeah, so this is the continuation of central retinal artery occlusion. So USMLE wants to show you an image that looks like this one. Okay, they want you to know that the weird crescent-shaped finding is called a refractile body and refers to an embolus. I'm assuming this is going to be longer, isn't it? No, it's not. It's just this. Diabetic retinopathy can present in numerous ways, such as with blurred or fluctuating vision and difficulty recognizing colors. The USMLE vignette will usually say things like a convol spots, soft exudates, hard exudates, and retinal hemorrhages. Soft exudates are small, whitish lesions on the retina caused by microinfarctions and or axoplasmic material. Hard exudates are lipoproteinaceous deposits due to leaky retinal vessels. Soft/hard exudates and retinal hemorrhages are seen classically in both diabetic and hypertensive retinopathies. Okay, so here's a little image right there for you. We also have this is normal condition of retina. This is a diabetic retinopathy. So we have a fovea, macula, retina arteriosus, retina venule, central retinal artery, central retinal vein, optic disc. Okay. What about diabetic retinopathy? You have hard exudates, convol spots, aneurysm, abnormal growth of blood vessels, and hemorrhages. Also says here for diabetic retinopathy, can be dry or wet, neovascular. Wet type can be treated with anti-VEGF agents. And if it didn't, I don't know how clear they were about that, but VEGF is used for angiogenesis. It helps encourage more blood vessel growth. Hypertensive retinopathy. Buzzy findings like atrioventricular, let's just say this, AV nicking. What is the AV? I'm sorry, but this is a little bit of a detour. What does the AV stand for in AV nicking? AV nicking. Okay, so arteriovenous. So buzzy findings like AV nicking, arteriovenous nicking, and arteriolar narrowing. Question can mention sausage-like appearance of retinal arterioles. So you have exudates, AV nicking, blot hemorrhage, convol spot, arteriolar narrowing, disc edema, copper wiring. So at first you might not necessarily totally comprehend it, but just pay attention to it and kind of figure out what distinguishes these as being characteristic. So when you see an actual image on the exam, you think, oh, of course this is hypertensive retinopathy, right? Dyslipidemia. Orbital xanthoma, cholesterol deposits left image, and corneal arcus, lipid deposits right image. Both can occasionally be seen idiopathically in patients without lipid disorders, the latter in elderly. So they're saying the latter in elderly for probably corneal arcus. Says here, corneal arcus, lipid deposits right image. Oh, interesting. Corneal abrasion. So corneal abrasion, scratchy or tearing sensation of the eye, can be caused by contact lens use or coming into contact with irritants such as sand, that is to say playing in sandbox with son or daughter. USMLE will either ask you for the next best step, where the answer is installation of fluorescein into the eye, or they will show you the following image, which is a fluorescein installation, and this ask you for the diagnosis corneal abrasion. Here, fluorescein is an orange dye that when dripped into an eye appears blue-green under the violet light. Anything blue is normal, anything green is abnormal. Interesting. So that's corneal abrasion description. Okay, it's part of that little explanation. What about subconjunctival hemorrhage? Buzzy image / spot diagnosis for USMLE, caused by bursting of superficial conjunctival vessels, looks sinister but self-resolves uneventfully. Wow, that's interesting. Can be caught, well, I mean, I said wow, I almost like forced that, but it is an interesting thing, to be fair. Because it does look kind of nasty, doesn't it? Can be caused by trauma or brief periods of increased pressure, i.e. severe vomiting or coughing. Wouldn't that suck? You cough and then you have that? Yeah. So we're approaching page 300. And I am 16 minutes in, so I'm going to take a break. We're basically about halfway done. Again, like the dermatology section, there's a lot of pictures here, and a lot less text per page, and so it's easier to get through this section. It's not a particularly long section to begin with, but I suspect it'll probably have another 15 to maybe at most 25 minutes to wrap up this video, including the break, I suppose. At that point, if it's 25 minutes. But it should not be a particularly long video overall. Hello again. So we're on technically wrapping up page 299. We'll finish up on page 307, but we'll go back. Let's go now to iris abnormalities. So iris abnormalities, starting off with aniridia, seen as part of Wagger, W-A-G-R complex with WT1 mutations, i.e. Wilms tumor, aniridia, genitourinary anomalies, and retardation. So look at that eye right there, that aniridia. There is a lack of iris, you could say. What about coloboma? Coloboma means whole of the eye, seen in Charge syndrome, coloboma of the eye, heart defects, atresia of the choanae, retardation of growth and development, genitourinary anomalies, ear defects. Coloboma is pretty characteristic. I always remember what a coloboma is. It's very strange looking, isn't it? Anyway, so albinism. Albinism can cause a pale blue or pink eye. Or pink, I should say pink. It says iris, right? Plural for iris, yeah. I would say irises, but they say irides. That's probably technically more accurate, to be fair. But the iris will be pink or light blue. All right, very, very low in terms of its melanin content. Or, I should say pigmentation. Maybe more accurate phraseology. What causes the, is it melanin? It is melanin. I just want to confirm, I just want to make sure I'm not mischaracterizing it. If you have brown eyes, that is because of melanin content. Okay. Lish modules. Iris hematomas seen in NF1. NF1 can present with axillary and groin freckling, café au lait spots, hyperpigmented macules, optic gliomas, tumor of the cranial nerve 2, neurofibromas, nodules under the skin, pheochromocytoma, and weird brain cancers such as ependymoma and oligodendroglioma. Well, that does not sound fun, but that is an interesting presentation. The iris hematoma seen in NF1 right here. What about brush fields? And here's another thing too. They might not even show you a picture for some of these things. They might give you a vignette where they talk about the hamartomas or something with a Lish nodule without even telling you, without even necessarily showing the picture. You just got to know that Lish nodule has all these other kinds of associations with it, and bear that in mind when they're asking for some sort of answer from you. Next is brush field spots, connective tissue deposits seen within the irides of some patients with Down syndrome. So here we go, connective tissue, brush field spots. Now let's talk about high-yield peds ophthalmal differential diagnoses for IM. So that's high-yield pediatric ophthalmology differential diagnosis for internal medicine. Orbital cellulitis. Infection involving tissue posterior to orbital septum, Staph aureus, most common cause, rare sequelae of adjacent infection, that is to say, or this, for example, from the paranasal sinus, medical emergency, requires IV antibiotics. Preseptal cellulitis is a less severe version of orbital cellulitis. Hordeolum sti, painful bump on the eyelid, Staph aureus infection of sweat gland or oil duct, treat with warm compresses, can occur at any age. What about a chalazion? Is that a chalazion or a chalazion? Painless bump on the eyelid, bump on the eyelid. Blocked oil duct, not an infection, treat with warm compresses. I would say warm compressions. Warm compressions, I think, would be more accurate grammatically. So again, sties you can use, treat with warm compressions. And for chalazions, you treat with warm compressions. What about retinoblastoma? A little bit of a different situation. The image shows a leukocoria, which is an abnormal white appearance of the eye on light reflex. Should be normally an appear red using a light reflex thing. Well, not light reflex, but light reflex. Okay, light reflex. USMLE wants you to know that the RB gene, retinoblastoma gene, you could say RB retinoblastoma, that's why it's called RB gene, mutation does not only cause congenital retinoblastoma, but also elevate the risk of osteosarcoma. So and this is talking about the RB gene mutation connected to retinoblastoma. In other words, classic question is that they show you an image above, plus they ask you the child is at elevated risk for what, and the answer should be osteosarcoma. So something to be aware of. Strabismus right here, means a lazy eye or misalignment of the eyes due to weakened muscle in one eye. So you have esotropia, inward turning eye, eso, inward. Exotropia, turning outward, exo, outward, external, right? Hypotropia, the eye is downward turning, hypo, below. Hypertropia, upward turning, hyper, above. Names are pretty reasonable. Hypo, below, hyper, above, eso, outside. Eso, interior, exo, outside. Think about the word exoteric means it's widely, easily available. Esoteric means it's difficult to attain. It's hidden, right? And so eso is inward, right? Anyway, strabismus can lead to amblyopia, which is reduced visual acuity in the weak eye due to the brain favoring the stronger eye during development. Strabismus, however, is not reduced vision in the weak eye. It precedes amblyopia if not treated with eye exercises and/or penalization of patching the strong eye. So basically, they're saying is that the way you could treat it is by trying to get the other eye to do more work, and by maybe making the strong eye a little bit weaker so they're a little bit more balanced out, you could say. So penalizing the strong eye, trying to get the weak eye to work out, I guess. Let us continue now to UV light-induced ophthalmological pathologies. So cataracts, progressive clouding or opacification of the lens leading to blurred or hazy vision, particularly in bright light with increased glare sensitivity. Can be caused by sunlight, but the most important cause in USMLE is diabetes mellitus, since high glucose entering the lens means a conversion to sorbitol via aldose reductase, leading to sorbitol has high osmotic pull, causing osmotic damage to the lens in cataracts. Recent changes in visual acuity can suggest new onset or worsening diabetes, can be seen in peds in congenital rubella, congenital syphilis, and NF2. Melanomas can grow from the conjunctiva and cornea, just be where they exist. That's interesting. Okay, melanomas of the eye. That's pretty crazy. Pterygium. Let's talk about pterygium right now. Pterygium, non-cancerous overgrowth of the non-keratinized stratified squamous epithelium growing from the conjunctiva, crosses over the cornea, clear part of the eye covering the iris and pupil. History of sun exposure is the major risk factor. Pinguicula, yellow-white benign lesion of the conjunctiva composed of protein and fat. It does not cross over the cornea. Sunlight is the major risk factor. Papilledema means increased intracranial pressure on USMLE. Papilledema refers to blurring of the optic disc margins due to inflammation of the optic nerve head in the setting of increased intracranial pressure. So you have an artery, a vein, optic cup, optic disc, macula, fovea. Optic disc swelling of blurred margin, disc hernia, peripapillary hemorrhage, venous engorgement. So now we're on page 305. Let's talk about high-yield autoimmune eye pathologies. Anterior uveitis. White blood cells in the anterior chamber are sometimes seen in flares of autoimmune diseases, especially sarcoidosis and ankylosing spondylitis. USMLE might sometimes just give you a patient with sarcoidosis and then ask what needs to be done in terms of follow-up for the patient, and the answer should be slit lamp examination to check for anterior uveitis. What about keratoconjunctivitis sicca? Dry eye or xerophthalmia caused by decreased tear production, classically autoimmune, either a strand-alone condition or as part of the Sjogren's syndrome. Latter presents additionally with dry mouth, xerostomia, and systemic findings such as arthritis. What about dermatomyositis? Causes heliotrope rash, violaceous eyelids. Do not confuse with malar rash or of lupus. Okay. Violaceous eyelids can also be seen in neuroblastoma in peds, albeit completely unrelated. I just mentioned it because it shows up on the NBME form. Okay. Miscellaneous hereditary conditions. So they're just trying to wrap things up here now. Miscellaneous hereditary conditions. Leber hereditary optic neuropathy. USMLE wants you to know that the mitochondrial disorders, that is to say, for example, LHON, LHON, presents as a triad of 1, eye/ear problems, 2, hypotonia, and 3, lactic acidosis, low bicarb metabolic acidosis. Other mitochondrial disorders names you could be aware of are MELAS, MELAS, mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes, and MERF, MERRF, myoclonic epilepsy with ragged red fibers. Heteroplasmy is variability of phenotype severity across offspring. Osteogenesis imperfecta. Collagen 1 mutation can cause the very buzzy blue sclera. That is, as far as the disease is concerned, that's the least of your concerns. But yes, they do have blue sclera. That's very characteristic. Alport syndrome, mutation in type 4 collagen, X-linked recessive. The answer in USMLE for eye and or ear problem plus red urine. What about Marfan syndrome? Can cause lens dislocations. What about homocystinuria? Can cause lens dislocations as well. What about ophthalmia neonatorum? Fancy way of saying neonatal conjunctivitis. Well, we have chlamydia, caused by C. trichomatis, D through K, this STD, presents usually greater than 1 week post-birth and can lead to pneumonia with a lymphocytic shift since chlamydia is obligate intracellular, so it requires lymphocytes for cell-mediated immunity to clear them, unlike extracellular bacteria, which can be cleared humorally with neutrophils. The chlamydia can drain through the nasolacrimal duct to the lungs, causing the pneumonia. Prophylaxis is treating the mom while pregnant if she has chlamydia. Treatment in the neonate who already has a conjunctivitis is oral erythromycin. NBME can give you a vignette of wheezes, crackles, and fever in a 3-week-old who says they were treated for chlamydia conjunctivitis 2 weeks ago with topical erythromycin at birth. But this is not the correct treatment since topical will not cover any organism that has already entered the nasolacrimal duct. Gonorrhea. Gonococcal conjunctivitis will present in the first week of life with yellow discharge from the eyes. The USMLE vignette will be vague where the student says, but how are we supposed to know it's not chlamydia? Just because it's the first week of life, that's it. And my response is, if they give you chlamydia ophthalmia neonatorum, they'll say, tie it to subsequent pneumonia somehow, since that is the high yield point. Prophylaxis for gonococcal is erythromycin ointment. Treatment is a IM third generation cephalosporin, usually intramuscular, because IM could be multiple different things in this context because it's internal medicine, but intramuscular third generation cephalosporin, usually cefotaxime in peds. What about chemical ophthalmia neonatorum? Chemical type. Chemical conjunctivitis is classically due to silver nitrate eye drops that used to be given to neonates for gonococcal prophylaxis. However, they have been replaced by erythromycin ointment. What about viral? Viral conjunctivitis will present as teary-eyed, that is either unilateral or bilateral, either itchy and or non-itchy. I've seen variable presentation in USMLE. You just need to know that this is the most likely diagnosis in both school-age kids and adults, and is caused by adenovirus, which is a DNA virus. Treatment is supportive with saline rinse. Allergic. USMLE wants you to know that a cobblestoning of the tarsal conjunctiva is buzzy for allergic conjunctivitis. Likewise, for allergic rhinitis, they can say cobblestoning of the nasal mucosa. Some students have asked if allergic has to be bilateral, which it need not be necessarily, and it doesn't have to be itchy either. But you have cobblestoning for allergic. That's a characteristic of it. Finally, we have herpes viridae infections. Let's talk about it. Herpes keratitis. Keratitis is inflammation of the cornea. HSV1/2 can cause dendritic, tree-like pattern in the eye on fluorescein installation. May or may not cause vesicles around the eye as well. Treatment with topical acyclovir/valacyclovir. Herpes zoster ophthalmicus. Varicella zoster virus, VZV, HHV3, can cause shingles of the eye. That doesn't sound particularly fun. Causes keratitis with similar dendritic pattern to HSV1/2. May or may not cause vesicles around the eye as well. Treatment would be topical acyclovir and valacyclovir. So very, very similar to the herpes 1/2. CMV retinitis. The answer for blurry vision in severely immunocompromised patients, usually AIDS. You do not need to know the fundoscopy. You treat with ganciclovir. Okay, and that is the end of the ophthalmology section for the Mehlman Medical Internal Medicine PDF. So, if you found that video interesting, I guess, if you're really into this stuff, smash that like button, subscribe, that kind of stuff. And regardless if it was of good utility to you, and regardless of that, have a great rest of your day. Thank you, and goodbye.